as we all talk about communities, as we all talk about patients, I think we have given enough name to the person who need the health care. Okay, so maybe I want to jump into the quick question with Anshu, because while we were talking outside, he talked about a customer, how a for-profit world looks at a customer and how a not-for-profit world looks at a customer. It is not to separate the two worlds, but just try to get a perspective on how we look at the customer, who is the person who needs healthcare here. So yes, Anshu.
Just to give a perspective, if you see the difference in the for-profit and the not-for-profit world, fine. I mean, of course, health sector somewhere comes in between, but the fact remains that the for-profit sector is a happy customer to sell your services or sell your products. But if you see the not-for-profit sector, from where many of us come now, I mean, of course, our career started with the for-profit, but now moved to the not-for-profit. So maybe a little bit we understand both. We are unfortunately looking for a person in grief. Our entire life is actually spent in just looking for people in grief. Right? And it's very complicated to handle grief of people. And then with that also you need to look for an okay life and all that. And the other thing is that the way the for-profit sector keeps looking for a much happier person in many product range, that okay, this you can afford, now I need to move to the next level, I need to sell my iPhone 17 kind of stuff, because you already have iPhone 16. I think the irony of this sector is कि हमको और दुखी लोग चाहिए. That is the worst thing. कि okay, this segment is okay, they are still okay, government is taking care, other people are doing it. Now can we move to the other places where people are, facing problems?
So on that note, I will go to Dr. Evita here. And the question is, her work is very deep and transformative in the Midwifery initiative. And you have turned nurses and midwives into strong community anchors for respectful maternity care. So what have you learned about how to identify and nurture such grassroots champions inside the public system?
When you're talking about a midwife, I need to just explain to the audience here. We are not talking about the traditional birth attendant who would have birthed our grandmothers. We're talking about a nurse who is trained to global standards and who now takes charge of two lives, the mother and the baby. A nurse generally takes orders, but when she trains to be a midwife, she takes charge. So she actually takes care of pregnant women who are healthy, who have no complications, which today form about 40% of the pregnant population. So when you empower a nurse with knowledge and skills and say, now you are capable of offering care. So considering India has 25 million births a year with 60% in public hospitals where there's overcrowding, and a woman, when she's giving birth, it's the most significant moment in her life. And if there's a death, most of the deaths happen around childbirth. So these are preventable. So when you've got this new professional cadre and put her into the community, she becomes an agent of change. And that's what's happened in Telangana, Andhra, where we have trained. In Telangana, we've trained 353 nurses who are now posted in clusters across 50 district hospitals. So where you have midwives, they ensure, because the philosophy is based on respect, kindness, dignity, privacy. Skills and knowledge is a given, but this comes with the midwifery philosophy. And so you don't see disrespect and abuse. Mothers today in public hospitals have a birth companion and can birth in position of choice. So it's transformed the landscape for the poorest of our poor women who are forced to go into public hospitals because they have no choice. But today they have a voice because the midwife is there to advocate for these women.
Great. Thanks, Evita. And also just to follow-up question on that, because the women in labor is always looked at vulnerable. How do you turn around from that perspective of the other person from a respect perspective? So would you like to highlight that point?
Yeah. I think your question is, how do you transform the nurse into becoming a more compassionate?
Yes.
Yeah.
And how do they look at not just the patient who is delivering,
Yes.
but there is a new birth happening.
Yeah.
So how will that perspective comes into the person who is helping that happen?
Right. So this was the first time I was training nurses, and we had a small group. I had a nurse, a midwife from the UK. So how do you get that transformation or bringing that whole perspective of looking at a woman not as a patient, but a woman who is pregnant? And how do you bring compassion? So we started with talking about birth stories. And I discovered that women remember everything surrounding their birth. So when a woman is traumatized because the staff has been disrespectful, her privacy is not intact, it remains with her and she's scarred for life. So in this first batch of 30 nurses, seasoned nurses, I may tell you, we spoke about birth stories, and then the penny dropped. Because out of 30, 25 were mothers, and they began to talk about their own birth stories, and each of them was traumatized. So what began as a lecture turned into a transformation, and soon these 30 nurses said, "Good God, we've never spoken about this, but we carried this trauma for years. We will never, ever treat a woman in labor the way we were treated."
Thank you. That is really, I always get good bumps and really amazing, Evita, on how you are looking at very differently and not the top-down approach, which is always looked at, sorry to say, in the hospitals or in most of the places. So I'll go back to Anshu and then to Mukti. So Anshu, Goonj and Swabhimaan have shown how surplus can fuel dignity first, community-led change, and what conditions need to exist in a village or a basti for a true health change maker to emerge from within.
We are still struggling with the very basics. The moment a disaster happens, a lot of material comes from the cities. And what we get, even in medicines and all, or this medical support, what we get from the cities is maybe some medicines for hypertension to diabetes to cancer, whatever. And what that particular region right now need is just maybe some basic medicine for your stomach, for some pain, or some ointments or something for the injuries. Okay, or maybe a lot of betadine kind of thing. Fortunately, we can say a lot of bad things about RMPs, registered medical practitioners. We can say a lot of bad things about it. And of course, I'll not say that this is the best possible system. But this country already has a very vibrant culture and education of, say, RMPs. And more importantly, the entire ASHA worker, segment with different names and all. So you already have those. The only important part is that how do we build their capacities till the time we have much better healthcare. They can handle it. And to be honest, COVID was one of the biggest proof of that. Every single medical system which was ignored or discarded by this country, right? Whether it is a small PHC in the village or a ASHA worker or an RMP, at the end of the day was there to give vitamin C, crocin, whatever was needed at that particular time. Otherwise, we would have failed miserably. These were the people who were there. So what I'm trying to say is that it exists. We need to recognize that. We need to equip that with the very basics instead of thinking like a very ultra modern stuff. Right now, whatever exists need to be better. That's the most important part. I mean, we work massively on, we were the first people to talk about menstruation in the country. And it started in 2004-05. I was there in a place called Firozabad, next to Agra. And that is where a lady shared that how one of her sister used a piece of blouse which had a hook, and she died of tetanus. That was an absolute eye-opener. We never thought about it, although we started working on the issue of clothing, but we never knew about it. And then we started exploring all across the country that what is this happening. And it's not this issue limited to India. This is a global issue. That how even today, millions is a very small number in India, we all know, sitting in this place. Crores and crores of women and girls are using sand, ash, jute bags, rugs, racks, newspaper, grass, cow dung, anything and everything which can stop or which can absorb. Right? The biggest reason for uterus removal is lack of that small piece of cloth. I mean, I am saying cloth, but it could be anything. Now, the problem exists. Okay. Solution is not very expensive. I am saying that till the time we provide proper sanitary pad to people, even if we just work on the education and tell people that all these boils and itching and white discharge also happen because of this, fine. And you don't notice this because this is a very simple women's health story in India and in many other countries. We don't even question that. We take it as part of life. So see how if we just make sure that even if the product is not available for the entire country or the entire world, a good kind of very desi, very localized information and awareness is available. Okay? Things will start changing. Yeah. I mean, we created out of a piece of cloth. And you'll not believe, Gopal, after using that, we all can debate, kapda acha hai, nahi hai. I mean, in the world where if not my mother, at least maybe her mother must have used a piece of cloth. Yeah? But when they use it for a month or two, that is where they are able to realize that it is a health issue. But after using something clean, because they never had access to a clean thing. So that's what I'm saying. Infrastructure is there. Just a little bit of our effort and willingness and understanding that it's not a women issue, it's a human issue. If we just solve this little bit of problem, half of health issues in village India or with the communities will not even happen.
Great, thanks. And this also highlights how the bottom-up approach happens. And the most important thing is respect towards the person who are giving healthcare. And when you see people who are needing and providing the healthcare, that's where Mukti's work is through the community health entrepreneurs, where she empowers, she brings up those women who become healthcare providers. So Mukti, how has been your experience? I know it's not easy journey to train people, to bring them up to this level. So what is that inflection point you think has helped them to become community health providers?
Healing Fields Foundation, till date we have trained about 8,000 women, more than 8,000 women in that many villages across India. Before we went on the journey for the community health entrepreneur, we were doing health financing and micro health insurance. And we said that we need to provide cashless service as all of us have. We were the first ones in the country who came up with a post-hospitalization treatment as well as a co-payment so that there could be that the people can question the healthcare, the hospitals for overcharging, etc. We had a facilitator at the hospital. So after treatment, the facilitator would go into the villages to train the people and how to prevent illnesses. At that point, about 25, 26 years ago, what we saw was basic information was not there. We did not have even Uncle Google, neither did we have AI, none of that. And so one of the women, that time, a lot of people would come to us with vaginal inflammatory diseases. I would send some of them, if 16-year-olds, to Evita because some doctor quack there has said do a hysterectomy. And what we realized is the woman there who had come to hospital for a vaginal inflammatory disease and was admitted in hospital and went back, and the doctor had given her suppositories. When our facilitator went into the community to check on her, how she was doing, this lady said, oh, that hospital, networked hospital, the doctor is no good. When we asked her why, she said, how can we swallow such a big capsule? Nobody had bothered to tell her the suppository is not to swallow, but to insert. And people were coming to us with repeated infections. And one thing, of course, like what Anshu said, is menstruation is a huge problem. And then the other one is contaminated water, food, which basic health and hygiene, which all of us take for granted. That was a starting of the training of the women. Now, who's the women that we pick? We go to the villages, spend a lot of time with the panchayat leader, with the ASHA worker, with the Anganwadi worker, with the SHG women to identify one woman who will stay in the village, who can communicate, who the community trusts. We do not take adolescent girls. We do not take young women because they would get married and go to their husband's village. So it has to be a daughter-in-law of the village whose youngest child should be a minimum of 5 years. Why is that? Because by then she would have been embedded in her community. And she will have a voice within her own house. And the child can start going to the Anganwadi center because we expect them to work for about 2 to 3 to 5 hours. A person who is trusted, not a medical person, not a degree holder, but who is willing, open to learn, and feels empathy for her community. That I need to learn something for myself, for my own betterment, as well as to the community I want to help. And we put them through a structured training program. Inflection point is after in the 3rd or the 4th month, they undergo the American Heart Association's First Aid Certified Training Program. And that training program becomes the inflection point because anybody falling from the tree and a child has broken an arm or a leg. This is the woman who is called a remote UP, where women even now are with Gungats. They live in joint family. So we had one of those typical UP woman in a remote village, and she was a community health entrepreneur. One day late in the night, one of us got a phone call and this lady was crying away. We were wondering what had happened. And she said, my brother-in-law is asking me to leave the house and go. Now, where do I go? So immediately we got the staff activated to go and check out what was happening. Next day by 6 o'clock in the morning, our training coordinator and field coordinator was in the village. Her husband's cousin, it was harvest time. They had harvested. You would have seen this huge tractors with trailers where they put the hay and they were taking it. And this guy fell from the top down. And everybody around came running, but nobody can do anything because he's bleeding, he's injured. So this lady also ran to the place and she was trying to tell, somebody told, "Ha, CHC Didi hai, kuch karegi." And this lady stopped because this is a stranger, even though it's from the same village, but as a UP Bahu, she is not allowed to touch anybody else other than her father, brother, husband, and sons. So she can't do the first aid. So she was trying to tell them how to stabilize the leg, how to put the sling for the arm, and nobody were able to do it. Then the husband says, "What are you talking so much? The guy is in so much pain. You come and do it." So she went and did it. She stabilized the leg, got the bamboo, splintered it up, and got a bed sheets, got the bamboo, made a stretcher, and got them to transport this man to the nearest hospital. The hospital, of course, the doctor said, "Who is this lady? Who has done this first aid?" And when he figured that this was a lady who was semi-educated And he was really happy and saying that saved his hands and legs, and the bandage to the head stopped the bleeding. Brother-in-law comes and says, how dare you touch a strange man? You will have to be thrown out of the house. You have to be excommunicated. It's a joint family. Next day, father visited the hospital. The doctor said, Badai ho, your daughter-in-law saved this man's life. And everybody comes and tells the father-in-law, you have a fantastic daughter-in-law. The fight is still going on in the house. He comes home, tells his younger son, you want somebody to go? Because of you, till date, I have not had any pride. You get out of the house, my daughter-in-law will stay.
Wow.
That is the inflection point. That is the inflection point and the change that happens.
But Gopal, just to what you were talking about, the infrastructure.
Yeah.
This story tells you that how much wisdom, how much great, how much everything is available locally. In this entire story, except knowledge, nothing went from the cities or went from outside.
Absolutely.
That is the story.
Yeah.
That's what villages or the communities are.
Absolutely. And this also, thanks Mukti for bringing the story up, and it's so evident. As we all know, the number of people stay in the villages. I don't have to talk when we are sitting in a place like India. And we have talked about the health infrastructure in city and other places, but what is happening to these places? And imagine if every village has got the community health entrepreneur, which Mukti is training, what kind of a world it look like. At least the first aid, at least the first response can start happening. So thanks a lot, Mukti, for bringing that story. So we have an interesting panel here. Just want to bring to everyone's notice. So we have Dr. Evita, Mukti, Anshu. They are the Ashoka Fellows who are part of the largest Ashoka global community. We have 4,000 such Ashoka Fellows across 96 countries. So they are part of that network. So I'm really happy to see our fellows sitting here and talking to you all. And we have people working across sectors, not just health. And interestingly, on the dais, we also have two interesting friends who we have Sri, who comes from a tech background, moving into health. Of course, he don't want me to tell him like a techie, but I still want to insist and want to bring all of you to his own story on how he started his journey as a tech entrepreneur in the US and then move into founding something called as REAN Foundation, where he's building platform to see how people can get help. So maybe on that note, Sri, and then I'll come to Suresh's story also. So Sri, you want to bring up the point. You have heard the three stories of how Evita, Anshu, and Mukti is doing, and you're trying to enable them. So how do you see that enabling? And I want to really bring your frustration out to the audience here. Like, what are you most frustrated about?
I come from a perspective, just to lay the ground, there's a lot of emphasis on access to care, which is very important. When we think about care, we're talking about, can I see a doctor or a patient? But if you magically solve that problem and 24/7, it's free for everybody in the world, I believe there'll still be a healthcare problem remaining because we as individuals are very bad at complying with the advice of our doctors, right? We take even very educated people, if you had a surgery or your parents had a surgery, you're given a lot of information. When you go home, then all the doubts start popping up. Can I eat this or not? How do I do my physiotherapy? Those kinds of things, right? So now to bring it back to, if we take a health worker, ASHA worker, and we talk about COVID, they are bombarded with, they're the solution to every problem. Like, maternity care, COVID, hypertension, TB. Now think about, you keep on getting these trainings. How do you remember what is needed when it is there? So we all retain hardly 10% of what we learn. But when we have a need for it and when we can get access to that information is when we really change. That's one aspect of it. The other aspect of it is the whole of public health is set up in such a way that they're collecting a lot of information on paper, and all that is good for statistically at some district level, state level. For that individual's health, there is no clear answer. So what motivation would that individual have when that ASHA worker shows up next time asking to fill another form? Right? But that's how this whole thing is structured. And, as technologists, we kind of tend to take a hammer and try to find a nail. But the real problem, I think, I still don't know what value we add. So the need, nobody argues. There is always a need from a patient perspective, needs a companion to advise them exactly on what to do. Health worker needs that knowledge, right? From a value perspective, it's very easy to jump in as a technologist to the solution. But we tend to ignore that whatever we come up with needs to fit with the existing workflows. And it needs to reduce the cognitive load. So don't ask them to collect even more data. Give the actionable insights that they can do, right? So these kinds of solutions, unfortunately, we bring very less to the table and we get surprised. And from their perspective, there are 100 technologies coming at you with a hammer and they don't want any technologies in their face. Right? So it's really being able to associate yourself, understand the need on the ground, and not what ChatGPT tells you or what brilliant people told you, right? So that getting to that, I think, is the real problem.
We were also talking because one of the major issue which Sri was telling is when he tracked people's health indicators, and then he also helped people remind on taking tablet, but then also they miss taking tablets. So the question we were asking is, if AI takes the tablet, will it solve the problem?
Yeah. So right, I tend to say, like, AI is nothing is going to solve that problem in 100 years. AI is not a solution to that problem, right?
Yeah. So on that note, I want to go to Suresh, who is really from a product mindset, working at Solix of technologies, and so Suresh, you are seeing so many solutions being thrown with a hammer and looking for the nail. So how do you see this solving? Because there are more solutions for all of your information than the problems. So how do you see one is this gap? And also, how do you see the problem of adaptation? Because there must be some gap, because if there are more solutions and less problems, but the problem is not still solved. So what is happening here?
Basic fundamental when technology enters a space is for two things, right? Initial cost is high. Challenges will be there. But the purpose of technology over time, you can see in any space, is to scale and to reduce the cost, right? These two are the major problems in any nonprofit activity too. You can see it from day in and day out. Whatever care we are trying to give, these two are the critical ones. Now, what Solix and our TAL initiative is to create a platform around this as much as possible. Yes, we are building up the specialities in that platform, but technology has its own bound. It will stop at some point, because the point of care is critical. That's where I love the story each one of you brought in, because technology has its breadth and depth over time and it can scale massively. But at the point of care, somebody has to use that, right? And has to educate that, bring that awareness to the community, because at the end point, not everybody has got the access, or in terms of having a smartphone, downloading the app, they won't have it. But with right awareness, right help at the end care, it will definitely scale. That's my first take on this, actually.
Great, thanks, Suresh. So you can see the bridge where we need social entrepreneurs like them who bring that adaptation in place, which actually make it more contextual for the person who need the care and what technology is providing. So I'll go back to our three change makers, what we call them, and want to ask each one of you, if you want to get the audience here engaged, how do you think they can engage? So we have the entire health fraternity here. How do you think they can be better engaged in activating the community more and more, so they take charge of their own health and don't look up to for the outside help? Of course, they need outside help, but for the first responders, what do you think the room can do to join you in your missions?
From the maternal health perspective, because I look after pregnancy and childbirth, so we're looking at birthing the new humanity. And I would urge every young man here who's going to be a father or who is planning to be married and to be a father Get your wife to be empowered, take charge of her health, get all the information she needs before she gets pregnant so she can be fit and give birth to a healthy child, because the next generation gets a better deal. The other thing I would urge everybody who's connected with young women who are going to get pregnant, there's nothing better than a normal birth as against an unnecessary C-section. There is enough data to show today that children born through C-section are deprived of the immunity protection from the mother's microbiome, but they lose because they don't come through the normal birth canal. So these children are starting life already on the back foot. So these children, when you actually follow them up, they end up with obesity, childhood diabetes, asthma, and many other conditions, including autism. So please, take charge, encourage your wives, nieces, sisters to look at normal birth rather than an unnecessary C-section, because we are talking about the next generation.
The death from a financially weaker section person in that society cannot be taken for granted. I mean, we have been arguing about this, that every single woman goes through a very complicated 9-month process. It's easy to say कि इतने बच्चे हो गए and enjoyment and all that kind of nonsense thing. But the fact remains that in the toughest scenario, women are giving birth, and again, and we know, because when we talk about, when we deal with people, and I think all three and many of us know, many times the women actually, the first thing which she asks for is a tablet. And the tablet, because she does not want to give birth to one more kid. If that is happening, that is a failure of us. Fine? No one is willingly doing that. So it's very important that we really get into some deeper issues and see that deaths are not taken for granted. It's emotional, it's physical, it's a whole lot of burden. Number 2, we all know, even in our families who are comparatively much more privileged, that if one person is hospitalized, the entire earning, the hard work of the entire family goes away in one go. Whole lot of us have lost a lot in COVID. Fine, a lot of people have not come back to the normal life that way. So how do we really take care of that? And the third part is that I think I always say that this is a fight between killing a mosquito or treating malaria. Fine. The small example which some of us have given, or the small example which I just shared about a small cloth-based sanitary pad or any other solution, is about killing a mosquito. Once you kill that mosquito, you do not have to treat malaria in any case. So whole lot of us with so much of experience, with so much of resources, with so much of knowledge, which to be honest, I didn't have. I was not a doctor at all. I'm sitting with a doctor, but I was not. And none of us in our team. You guys are really much more experienced, much more talented. You are not looking for happy customer like us. In any case, people in grief only come to you. It's very important that all of us just get into treating these, or rather killing these mosquitoes, so that the malaria doesn't happen. It's very simple, and that's in your hand.
Great. Thank you, Anshu. It's Mukti.
Yeah, what is it that the people from outside and all of you can provide for the poor? One of the things that we always say is the trained medical professionals treat an illness. They're very important, very vital. But a trusted person within the village to be available, so that the person can go to this person and ask questions that they are not comfortable asking the doctors. I have nothing against the doctors. It is just that we are all a privileged group. And Our language, even though we speak the same language, is different. And that woman, that elderly, that young girl is more comfortable and not intimidated. So we need to have a person. Apart from that, technology. Anshu talked about COVID. You talked about telehealth. During COVID, I mean, that was a very, very important point in the 25 plus years life of healing fields and in my 50, 60 plus lives. That is the one time event that all of us saw, life event, pandemic. We sent from healing fields about 50 buses to the remote villages. By then we had our women calling. People, migrants were coming into the villages. There was so much fear. Nobody wanted them. Even the family members were not allowing them to get into their homes. There has been a lot of suicides because my own mother, my own father, my own wife is not allowing me to enter into the houses. And there was a silver lining. Many of when the people were coming back from Bombay and Delhi and Chennai and Bangalore, they were all going back. And the village said, CHE Didi ka paas jaiye.
Wow, wonderful.
And the CHE Didi, believe me or not, group of them called us. We quickly set up quarantine centers in the primary schools, in the panchayat bhavans, in the high schools. We supported them online. They had no clue of online technology. They started attending classes. We educated them, sitting in our comfortable homes about COVID. These women took charge, cleaned up, men separate, women separate, community kitchens were done at the community level. We set up telehealth centers with doctors who were calling. We airlifted paracetamol. We airlifted zinc and vitamin C from Hyderabad to these places because Bihar and all, the stock was over. And the Asha workers, government people were being chased out of the villages because there was a whole lot of rumors and fake news going around. The CHC took charge. And those days we used to get about 10 to 20,000 telehealth calls a day from these quarantine centers from the villages. Today we get about 60 to 100. And the difference, we looked at that and the difference. At that point, there was nobody available. So technology and WhatsApp calls took a leap. But today, we still need that one person. It has to be high technology. It has to be high touch.
Just one question, and any one of you can take. How do we bring care, trust, empathy, respect, love before the technology or medical science come into place? Because I'm realizing that is most important as a first responder. And then second, the medical science or technology comes. So any one of you would like to take that question?
My point is that by listening and by respecting as it is, by respecting because people are born with self-respect. We might be very privileged that we have studied in the best possible universities and all, but we cannot challenge the traditional wisdom. At the end of the day, COVID, everything which the village communities have been telling us, lesun khao, adrak khao, nibu piyo, all that kind of thing. Ultimately, we all were dependent on that, but that's the wisdom.